डॉक्टर की बड़ी लापरवाही सामने आई है। फिलीपींस से आई 4 साल की बच्ची की गलत आंख का ऑपरेशन कर दिया गया।
Wrong site surgery, an error in the operating room again.
Most recent incident of wrong site surgery.
Close call at a local hospital. Surgeons at the hospital prepped the wrong eye of a patient.
The state implemented a uniform process for surgical procedures this past summer. Wrong site surgery shows there's still work to be done.
A never event is a medical error that is so egregious that it should never happen. These are errors that are unambiguous, entirely preventable with the appropriate safeguards, and serious enough to cause significant harm to the patient. Unfortunately, medical errors account for more deaths than all other types of accidents combined. In low to middle income countries, 134 million adverse events are reported annually. In high income countries, 1 in 10 patients experience harm while receiving hospital care. Globally, 4 out of 10 patients are adversely affected by the healthcare industry. While 80% of this harm is preventable, at least 5 people die every minute due to unsafe care. Ophthalmology, unfortunately, ranks among the highest medical specialties for reported adverse events, with 1 in 10,000 procedures being incorrect. Earlier, one disease had one treatment. Today, there are several options. One can easily get caught in the tangle of similar sounding IOL names. Moreover, some IOL powers look similar, and it is easy to get confused and make an error. Additionally, studies indicate that 1 in 6 people experience left-right confusion, which is a significant concern in ophthalmology. The multiple reported events represent just the tip of the iceberg, as many more incidents go unreported, highlighting the seriousness of this issue. However, 2/3 of these errors are preventable by adhering to the Universal Protocol, which includes the following key steps. Pre-procedure verification includes confirming the patient's identity, the procedure to be performed, the correct eye to be operated on, and the correct IOL model and power. Site marking using methods such as a wristband or sticker to mark the site to be operated on. Timeout is a crucial step which involves a final verification of the patient's details just before starting the surgery. Non-compliance with the Universal Protocol is the primary cause of 2/3 of the errors, although some mistakes can occur upstream, like advising surgery on the wrong eye, or downstream, like opening an incorrect IOL. Thorough root cause analysis is imperative to prevent these errors. Over years of problem solving, we have developed a robust system to prevent incorrect procedures, which we shall now share through this video. Each patient receives an ID card with a unique number specific only to them. This number is required to access the case file, significantly reducing the risk of opening another patient's file by mistake. When advising surgery, a pop-up confirms the eye to be operated on, ensuring the doctor verifies the correct eye twice. Human error in transcription can lead to misinterpretation, thereby causing wrong IOL power or incorrect IOL type being implanted. Hence, we developed a system which is fully automated, wherein the patient's biometry is directly uploaded to their case file in the Electronic Medical Record or EMR. After the patient confirms their lens choice and signs the consent form, they receive an appointment slip to present on the day of the surgery. The list of the next day's patients, including their IOL models and powers, is downloaded from the software by the store staff, who ensures that the inventory has all the necessary IOLs set aside for the next day's surgeries. On the day of the surgery, the patient's case sheet details are verified against their appointment slip and unique ID. Verification is crucial at every step. The eye to be operated on is confirmed with both the patient and their attendant. The ID card is then attached and dilating drops are instilled in the eye to be operated on. After payment, a wristband with the patient and eye details is printed and placed on the wrist corresponding to the surgical site. The details are again verified and a sticker is placed on the site of surgery in the presence of the attendant. The patient is then moved to the daycare room where the perioperative record list and surgical checklist are attached to the case sheet. After further verification, vitals are taken and recorded.
The first page of the case sheet containing the surgery details is then printed and verified with the rest of the documents.
In the block room, the patient is prepared for the operating room and their medication history is re-verified and entered. For surgery under topical anesthesia, the pre-anesthesia checklist is administered here and topical drops are applied. For subtenons anesthesia, the details are verified by both the OR staff and the doctor. The IOL power on the case sheet is confirmed with the A-scan and the pre-anesthesia checklist is administered. The instrument set is kept on the side of the eye to be blocked. The patient is blocked in the presence of an OR staff member to avoid any acute events of wrong side block. The lens is obtained from the store after entering the patient's details and scanning the barcode on the IOL box. Avoid incorrect lens dispensing. After verification, the patient is then moved to the OR. Here, the details are checked against the wristband and a before incision checklist is administered by both the doctor and the assisting staff before the surgery begins. Before opening the IOL, the patient's wristband and case sheet are again verified by the assisting nurse. After the IOL is implanted, the surgery is completed. The post-op checklist is administered just before the patient is shifted out of the OR. The checklist data is then entered into the EMR, ensuring that the surgery is performed on the correct patient, the correct eye, and with the correct IOL. It is crucial to perform a comprehensive timeout and utilize checklists managed by multiple personnel to ensure maximum safety. Regular training sessions should be conducted to reinforce all aspects of this approach, especially with new staff members and the OR team. Among the 10 goals at ARAVIND, these safety measures are the highest priority. Our goal is to be 100% correct and not 99.99%.
Volume of surgery had spread around the world, but the safety of surgery had not. We looked at the aviation world, and we found that they have technology, they have training, and then they have checklists. We did this. We created a 19-item, 2-minute checklist for surgical teams. Complication rates fell 35%. The death rates fell 47%. This was bigger than a drug.